Dr. Collins, on what kind of research efforts do you envision we need this, and what problems do you think are most likely benefited by research? And we may let's do those first. We may come back in a second round about what's that going to cost. But talk about what's needed, where the partners may be, and where do you see the greatest promise of those dollars producing a quick result?
Mr. Chairman, I appreciate the question because that's something many of us are spending a lot of time working with partners to try to identify what the needs are and how we can meet them. I would put them in two categories. There is the shorter-term need where we need to have better options for medication-assisted treatment, and we need to have the evidence to show what actually works and results in long-term outcomes that get people free of addiction and are not associated with relapse. We need better treatments for overdose. What we have now with Narcan, and I showed you the example of the nasal form of this, which we had a lot to do with working with the company, that works really well for people who have had overdoses of heroin. We are concerned that for fentanyl and carfentanil that are even more potent, that the Narcan may wear off and then the respiratory arrest recurs. And so we need longer acting, more effective overdose treatments. So those are short-term needs and ones that we believe working with an associate group of companies, and we have 33 companies we're now working with on a partnership for which we've had a total of already 7 meetings and another major one next week to work out the real details of what would look like an action plan, and we're quite far along with that. The second area is somewhat longer term, but if anything more important, and that is to develop effective but non-addictive, potent pain medicines. We don't want to abandon those.
Let me ask a question about the Narcan. Mm-hmm. How does the nasal treatment that has been developed, how does it compare cost-wise to the previous intravenous treatment of that?
It's substantially cheaper. So this particular version, a dose pack of 2 of these is about $70, whereas the injectable form is about $4,500. And if you look at use by first responders, the nasal version has now greatly outstripped the injectable form in terms of what first responders now have access to, in part because it's cheaper, but mostly because it's easier to administer, doesn't require any special treatment, just a blast in the nose.
Anybody can answer this that knows the answer. Who provides that to the first responder? That's locally provided by the... Right. So that's provided locally.
Indeed, and the local municipality has to find a way to pay for it.
I want to come back later to the whole partnership and how that might be financially involved. I'm going to run out of time here. Congressman Kennedy, stigma is something you and I both talked about for a long time, looking at behavioral health differently than other health. How do you see that relating to people's reluctance here to ask for help when they realize they've got a problem but still are bound by that stigma of going out and asking for help?
Thank you, Mr. Chairman. Thank you, Mr. Chairman. Obviously, attitudes are a huge, huge barrier, but the barriers that insurance companies place before people when trying to access treatment reinforce stigma because it makes people feel like that they really shouldn't be getting this care because it's really not real medical care. And that's why this Millman report, which I've made available to all the members of the committee, just came out, showed a scathing report on insurance noncompliance with the Federal Mental Health Parity and Addiction Equity Act, which you all supported, was bipartisan bill. Frankly, without its proper enforcement, which you as a committee can actually help through an additional appropriation of $17 billion, 15 for the Department of Labor, 2 for the Solicitor Generals, in order to oversee enforcement of the federal mental health parity law. You can actually leverage a lot more resources to this crisis that should be coming out of these insurance companies, who, by the way, when they neglect to cover people with these illnesses, only forces those folks onto the federal payroll, so to speak, through criminal justice systems, through Medicaid, Medicare, and the like. So, Mr. Chairman, I made a recommendation to the committee that you give Secretary Acosta, and by the way, I've personally met with Secretary Acosta. He wants to be aggressive with the insurance companies. 70% of all health plans, ERISA plans, come under his jurisdiction in the building like 3 blocks away from here. So I hope There are some things this committee can do, and appropriating those dollars for greater oversight of the parity through the Department of Labor would be one of those.
Thank you. Senator Sheen, in her comments, Dr. Collins, and in your response to her, in the nasal injected Narcan that you mentioned that NIH had a lot to do with, does that reflect both availability of competitors to that product, or what can we do when there is a significant NIH involvement to share that research in ways that inject more competition earlier into the delivery process?
So that's a complicated dynamic, and I appreciate your phrasing it the way you did. We are very much in the place of trying to make everything that we do as public as quickly as possible. Certainly working in that particular instance, the real innovation was the mechanics of the injector and making sure that we got the dose in the right place, and then being able to show with appropriate data that this reached systemic levels that were going to be effective in reversing an overdose. That was a fair amount of work to do. But again, as a partnership with a company that knew something about formulation and injections of this sort was the way that it was possible. And it did end up creating a competition with the existing injectable form. We will continue to do everything we can to encourage those kinds of competitive things to come forward. We need a better antidote that has a longer potency than what we currently have.
Is that nasal products coming from one company now?
Yes, it is.
And if you're dealing with 33 companies or some portion of 33 companies, how would you envision that research going in a way that more than one company becomes the beneficiary of that research? That I think we're also, and you're envisioning that those companies also put some money on the table, right, in addition to their brain power and effort.
So let's talk about the development of a new effective non-addictive pain medicine. So we know that there are these projects going on in companies that are looking at things like that sodium channel that I mentioned. In fact, there are probably 4 or 5 companies doing that. What we need to do in the partnership is to identify the part of that that is essentially pre-competitive and then agree to share the data. I'm not sure 10 years ago companies would have been interested in that. They are now, because we've seen that work for diabetes and Alzheimer's disease and Parkinson's disease and rheumatoid arthritis in a different set of partnerships we've built with industry. So as part of this, there will be more data sharing. There will be, therefore, an acceleration of everybody's effort to get their drug actually to FDA for approval. You will want to see them compete with each other, and you'll also want to see out of the end of this the successful approval of more than one drug in a particular category so that the competitive aspects will drive the price down. That's our goal, to stimulate all that to happen.
Well, I'd like you to work with us in the report language or whatever whatever mechanism we need to use so that it's clear that we're encouraging that kind of effort, that if there's a matching fund or another fund that we anticipate would be augmented by the companies themselves, that there's a clear, that you have the clarity you need from the Congress, if we can give you any clarity, that this money is available in a partnership kind of environment, but we also want the result to be available as much as possible in a broader context than one company somehow being able to pick that up. So we'll continue to work together on that.
I'd like to do that.
Also, Dr. McCants-Katz, how long have you been in this job?
A little less than 4 months.
A little less than 4 months. So any suggestion that you've had this authority a long time and haven't used it would be not accurate. But we hope you do use the authority you have and be expansive in your sense of what the Congress has said clearly they'd like to see here. Mr. Kennedy mentioned earlier that his belief, which I share, that treating behavioral health like all other health will actually save money. And there are some large county studies that indicate that's the case, but you know, and we've talked about this before, we've got this 8-state pilot going on right now. It's 6 months into the 2 years. And I think the way that you collect information on that with an eye toward either proving or disproving the Kennedy Blunt theory here that if you look at the behavioral health population, which is substantial, NIH says 1 out of 4 adult Americans has a behavioral health issue that's diagnosable and almost always treatable. So 1 out of 4 is a pretty big group, and that 1 out of 4 has collectively lots of other health problems as well. And I think if the record produces what I think it will, every state that's not a participant should be able to look at that and say, we're going to save money if we do what everybody agrees is the right thing to do, treat behavioral health like all other health. But we're going to save money. We're actually not going to we're going to do both the right thing and save money doing the right thing. And this gives you an opportunity that nobody's had before to look beyond 1 or 2 counties, which in several cases have proven that this is what will happen. But let's see what happens in the context of 8 states. There's another bill that Senator Stabenow and I introduced to let you look at the other 11 states that went through the full process of applying to be one of the 8. 24 said they'd like to try it. 19 went through the full process. And we've got a bill, if we can move it forward, that would encourage you to look at the other 11 states. And if they meet the criteria, let's move this further, faster, so that we've got a bigger group, kind of down to Dr. Collins' million-person context of looking at healthcare generally, but getting that information available. And I'm specifically asking that you focus on getting it available in how it treats, how it impacts other healthcare costs. Will you do that?
Oh, yes, and we have an evaluation that is already articulated for that program and being done right now. We hope to have some information that perhaps I can share with you by mid-2018. So absolutely. And we also have the model of FQHCs, which integrate different types of physical health care and increasingly behavioral health care as well, which have been shown to be effective.
And I think in all 8 states, certainly in Missouri, the FQHCs are an important component of that delivery system. And I think we have 15 agencies with 200 different locations that are 6 months into this context of behavioral health being treated like all other health.